Now I want to talk about the cardiovascular effects of two important prostanoids, and this is prostacyclin and thromboxane A2. They are synthesized from different cells and they mediate vasodilation for prostacyclin coming from the endothelial cell versus vasoconstriction for thromboxane coming from the platelet. And this is just they act on different receptors. So there's a prostacyclin receptor and the thromboxane receptor, and they mediate vasoconstriction versus vasodilation. Another important characteristic is that prostacyclin inhibits platelet aggregation versus thromboxane promotes it. And let's look a little bit closer how that works and also what is the consequence. There's particularly pharmacologic consequence. So the prostacyclin is made by endothelial cells, so EC for endothelial cells. That's what's making the prostacyclin. And the prostacyclin inhibits platelet aggregation. And I also want to point out that we know already that the prostacyclin needs COX enzymes in order to make it. We discussed the synthesis, and it turns out that the endothelial cell is mainly equipped with COX-2, and that's what we need to make the prostacyclin. Now, on the other hand, the thromboxane is mainly made by platelets. So here comes our thromboxane, and this promotes platelet aggregation. Now, it turns out that the platelets are mainly equipped with COX-1. And so the thromboxane is made in a COX-1 dependent fashion. So we have now here the yin and the yang in terms of platelet aggregation, one that inhibits platelet aggregation and the other that promotes it. So what is the consequence and why do we care? And particularly in terms of drugs, in terms of pharmacology. So let's think about a very famous drug class that some of you may know, which are called the NSAIDs, which stands for non-steroidal anti-inflammatory drugs. So they're not steroids, but they're anti-inflammatory. Some of you may know what their mechanism of action is. They inhibit COX. And they are used for their anti-inflammatory properties because certain prostaglandins also trigger inflammation. So they inhibit COX, but most of them, and we can list here an example like ibuprofen is a very important example, or aspirin, when you use it for its anti-inflammatory action in higher doses. So most of them inhibit both COX enzymes. So they inhibit COX-1 and COX-2 inhibit. But some of you may also know that aspirin, when we use it in very low doses, like what is called the baby aspirin, the 81 milligram aspirin, actually is cardioprotective. So it prevents us from having an MI or stroke. So how does it all fit together? Well, let's think about aspirin in low dose. So it turns out that aspirin in low dose is fairly COX-1 specific. So if you use a very low dose, you're mainly going to inhibit COX-1. So here comes aspirin. Again in low dose. Only if you use it in low dose. But if you go higher, it inhibits everything. Okay, so if you use it in low dose, it inhibits mainly COX-1. So what are you going to do? So let's cross out this section. That's what we do with aspirin with the low dose. We inhibit COX-1, and therefore we're going to inhibit platelet aggregation, because now this is going to be the important part of the equation. We're going to inhibit platelet aggregation. So now the cardioprotective makes sense, because that means we're going to decrease our risk of MI and stroke. Because we're going to featuring the inhibition of platelet aggregation. So the platelets are not going to aggregate. We're going to have a decreased risk of MI and stroke. And that's why aspirin in low dose is called cardioprotective. Now, can we also wipe out the other part of the equation? Yes, we can, because we have drugs, actually only one, that inhibits COX-2 specifically. And this drug is called celecoxib. So when it was developed as a selective COX-2 inhibitor, hence the name selective COX inhibitor. And it's selective for COX-2. So now what are we going to do with celecoxib? Well, we are going to basically wipe out this part of the equation. Okay, what's going to be left? Promoting platelet aggregation. What do you think is an adverse effect? A black box warning, a risk. Increased risk of MI and stroke. So that should make sense. If you wipe out this part of the equation, you're inhibiting platelet aggregation and you have a decreased risk of MI and stroke. That's why we use baby aspirin. If you inhibit this part of the equation with celecoxib, we're going to feature the promotion of platelet aggregation and end up with an increased risk of MI and stroke. Now, some of you may ask, so what about all these drugs like ibuprofen, or if you use aspirin in 325 milligram? They block everything. So what is then our risk? Well, it turns out that if you block everything, there is still, you feature basically this part of the equation, meaning you wipe out that part, and you're going to end up with an increased risk of MI and stroke if you just block everything. And if you look on a package of an ibuprofen, well, it's going to be written on it, increased risk of MI and stroke. And that's just a consequence of the inhibition of COX-2. But that seems to be more dominant, so inhibition of COX-2 than the COX-1 part for our traditional NSAIDs.